Hi, welcome to the Canadian Hypertension Specialist Society series. I will be speaking today about fibromuscular dysplasia, or FMD. My name is Lisa Dubrofsky. I'm a nephrologist in Toronto, and a big thank you to Dr. Gregory Hundemer for peer reviewing this presentation. I don't have any conflicts of interest with regard to this presentation. I will start by presenting a case of a 48-year-old female with new onset hypertension. She had been followed periodically by her primary care physician, and it was clear that her hypertension had developed in the last 1 or 2 years. Her medications included amlodipine, 10 milligrams daily, telmisartan, 80 milligrams daily, and hydrochlorothiazide, 25 milligrams daily. Her blood pressure, despite these 3 medications, was still a bit above target at 138/86 millimeters of mercury. She had no previous medical or obstetrical history, and she was quite active, continuing to run marathons. She was a non-smoker with no significant family history. She had a normal eGFR, and she had no proteinuria. However, a renal ultrasound did show that her left kidney was 11 centimeters and her right kidney was 9 centimeters. So today we'll be speaking about fibromuscular dysplasia, which is a non-inflammatory, non-atherosclerotic disease of the musculature of the arterial walls, which leads to stenosis of small and medium-sized arteries. Aneurysms, dissections, and arterial tortuosity can also occur, but these are only considered FMD if in the presence of an FMD stenotic lesion, which is classified as either multifocal or focal. We no longer use the histological classification of medial, intimal, or adventitial because we very rarely have pathology on these patients. Rather, we use a radiographic classification, which is either multifocal or focal. And you can see here an example of the 2 types seen in the carotid artery. In multifocal disease, there's at least 2 stenosis in a vessel segment, which is what's often referred to as string of V's, whereas focal is 1 stenosis. Focal is thought to be more of an intimal fibrous tissue deposition, whereas often with a cellular component, whereas multifocal is thought to be more medial and adventitial. And these 2 subtypes of the disease actually have pretty different presentations. Males are more likely to have focal than multifocal disease, and patients often present younger with focal disease. And it's possible that these are actually 2 separate disease entities. The epidemiology of fibromuscular dysplasia is not super well understood, and the prevalence in the general population is really not clearly defined. We do know that in living kidney donor candidates, there's FMD found incidentally in about 3% of patients. Of course, living kidney donor candidates may skew in either direction. They may be healthier than the general population. For example, patients are usually normotensive if they're being considered for a kidney donation. On the other hand, they may have a family history of someone with severe kidney disease prompting the evaluation for living kidney donation. We also have some information of the epidemiology based on registry data. There's a European and an American registry. The US registry was established in 2008, and in 2012, they published data from their first 447 patients. The vast majority were female. The mean age of diagnosis was 52. The vast majority were Caucasian. And it's very important to note that there is likely a significant referral bias playing a part here, as these are registry patients who present with FMD either with symptoms or incidentally found, and then join this registry. Of note, very few, only 7%, had a family history of fibromuscular dysplasia, but there was quite high numbers of family histories of stroke, aneurysms, or sudden death. And so it's quite possible that there's an increased family history of undiagnosed FMD. Although women are affected more than men, both in this registry as well as in other registry data, case control studies have not shown an association with gravida or with exogenous hormone use. And the pathogenesis of FMD is not well understood. It's likely a combination of genetic and environmental factors. There has been an association with smoking and FMD, and smoking is also associated with earlier onset and more severe disease. I want to highlight here that renovascular disease is really two different entities when we talk about atherosclerotic disease versus fibromuscular dysplasia. And the true diagnosis of renovascular hypertension can really only be made in retrospect if blood pressure falls to normal levels after successful revascularization. So there's patients who may have renovascular disease that is or is not causing their hypertension. But just to highlight that because atherosclerotic disease and FMD have different epidemiology, different pathophysiology, and there's different investigations, management, and follow-up, we really can't take data from studies looking at patients with atherosclerotic disease and apply it easily to FMD. For example, the studies looking at revascularization with atherosclerotic disease do not apply to patients with FMD. And when we talk later about investigations with regard to, for example, ultrasound, the sensitivities and specificities that are provided for atherosclerotic disease do not necessarily apply to patients with FMD. So what are the clinical features of fibromuscular dysplasia? Well, it can really affect almost any small or medium-sized artery, but most commonly, FMD is found in the renal and the extracranial carotid and vertebral arteries. And so most commonly, patients present with headache, usually of the migrainous type. They can present with pulsatile tinnitus, dizziness, as well as stroke or subarachnoid hemorrhage or intracranial hemorrhages. In patients with renal FMD, most often they present with hypertension, and it can certainly look like primary hypertension. As we saw in the previous slides, patients often present in their 50s. Patients can also present with a renal infarct. SCAD, which stands for spontaneous coronary artery dissection, is actually quite rare in patients with FMD. However, patients with SCAD have a very high prevalence of FMD, up in around the 50% range. FMD can also affect the abdominal arteries, causing postprandial abdominal pain, or the extremities, causing claudications. And of course, this can also be an asymptomatic incidental finding that gets picked up on imaging that was done for another reason. So in a patient with hypertension, when should we suspect renal FMD? We should certainly expect it we should certainly look for it if there's FMD in another vascular bed, and I'll get to that a little bit later. If there's an unexplained asymmetric kidney size, so that's considered more than 1.5 centimeters, which is what we saw in the patient that I presented. Patients with a family history of FMD and any symptoms of FMD, including hypertension, should be screened for FMD. And if there's an abdominal bruit. So these first four are what's listed on the Hypertension Canada guidelines that are currently out right now in the fall of 2024. But many guidelines tend to sort of lump renovascular disease into one entity. And so other guidelines may suggest looking for FMD in young patients with hypertension, specifically women, as well as in patients with accelerated malignant or drug-resistant hypertension. So the ACC-AHA 2017 hypertension guidelines, as well as the first international consensus on FMD, which is a very useful document that I will refer to several times, they do suggest screening these patients who are young or either have resistant hypertension. But overall, I would say really the data is lacking about when to investigate for FMD and also how aggressively to investigate. There is, of course, a differential diagnosis when we think about FMD, and this is not an exhaustive list. The first international consensus statement does have a much more exhaustive list. When we look at multifocal FMD, there's an entity called systemic arterial medulosis, or SAM, which is a non-inflammatory, non-atherosclerotic disease like FMD. Most often it affects the abdominal visceral arteries, and it can present with occlusions, aneurysms, dissections. And the definitive diagnosis is actually made by pathology. Sometimes patients present with imaging artifacts, either on MRA or CTA, which are suspected to be FMD, but then turn out not to be. And if someone's having an angiogram, arterial spasms can also occur. Patients with focal FMD on the differential includes atherosclerosis. Usually patients with atherosclerotic disease would have some risk factors for atherosclerosis, such as diabetes or hypertension or chronic kidney disease, or have a history of atherosclerosis in other vascular beds. Also, atherosclerotic lesions are usually more proximal for example, they'd be closer to the aorta in the renal artery, versus in FMD, it's usually more distal. Vasculitis is also on the differential diagnosis, but we would expect some other systemic symptoms and features, symptoms like fever, weight loss, or high inflammatory markers on labs. And then with regard to spontaneous arterial dissection, sometimes this does occur in the renal artery. Patients typically are middle-aged, and when we look for FMD in other vascular beds, we don't see it, or any evidence of FMD other than this spontaneous arterial dissection. And usually this does not reoccur, and it's sort of a one-time entity. The natural history of fibromuscular dysplasia is really not well established. It's believed by experts to be a non-progressive disease, but there's really not that much data to support that. There's one retrospective study of 146 patients with cervical artery FMD, where they looked for whether these patients had further evidence of FMD on follow-up imaging. This was a mean of 35 months of follow-up, and this was done between 2003 and 2015. And in this population, they did not see any evidence of new cervical lesions. Of note, 94% of these patients had multifocal FMD, so really it's mainly patients in that population. And in that time period, they were not looking systematically for FMD at other vascular beds. We really don't know anything about the renal arteries of these patients. 3 patients did have a new carotid artery dissection in the first 2 years after initial FMD diagnosis, but this was in areas of already known multifocal FMD. There's also older data from 1981 showing that there was angiographic progression in a data set of 42 patients. So we really, this is limited data. In the registry data of note, patients who have only one vessel involved are generally younger than patients who have multi-vessel involvement. And so some people point to that and say that maybe new vessels develop FMD over time. But overall, I'd say this remains inconclusive. So with regard to screening and diagnostic tests, the first step is a non-invasive diagnostic test. And the most preferred test is a CTA. That's because CTA has better spatial resolution than MRA, and it also visualizes calcifications that can better identify if there is atherosclerotic disease versus FMD. Of course, CTA comes with some radiation exposure versus MRA. So if the CTA is contraindicated for any reason, then an MRA is preferred. The diagnostic accuracy of both MRA and also duplex ultrasound in particular is really not well defined for FMD. Most of the studies looking at that included a vast majority of patients with atherosclerotic disease. The position statements and sort of expert recommendation is that duplex ultrasound should only be considered in highly qualified centers. But even in these centers, I would say accuracy is really not known. And we've seen cases in our center with a normal ultrasound, and then further imaging does show FMD. So I would say that normal ultrasound does not rule out FMD. If FMD is either very much expected or suspected, or if the CTA or MRA or duplex points to it, then the next investigation, which can also be a therapeutic intervention, which I'll talk about later, would be catheter-based angiography. And this is really the gold standard for investigation for FMD. This is a nice image, again, from that FMD position statement, showing that really imaging alone does not determine the hemodynamic significance of a renal artery stenosis in FMD. So you can see here that all of these images are sort of the nice string of beads, multifocal FMD appearance. But when a translesional pressure gradient was taken via angiography, there's varying degrees of stenosis that are actually in these arteries. And in picture D, there's actually no stenosis or no significant stenosis here. And so translesional pressure gradient measurement is recommended in order to determine if a lesion is hemodynamically significant, and imaging alone is insufficient. So now back to the case. Various imaging options were discussed with this patient. You'll remember that the patient had a size discrepancy on a plain renal ultrasound of her 2 kidneys. And the decision was made to proceed with CTA, which did show that there was a focal FMD stenosis in the right renal artery, which was the smaller kidney. Overall, the patient did not have any symptoms, but blood pressure is a little bit above target on amlodipine, telmisartan, and hydrochlorothiazide, which is 3 medications. So what further investigations does this patient need? I'll introduce now the Arcadia trial, which was a prospective study of 469 patients in France and Belgium who all had symptomatic fibromuscular dysplasia. In this study, all patients had systematic angiographic evaluation. So there were 304 patients who had kidney disease or kidney FMD, and all of those patients had imaging of their head and neck arteries. And then in the 164 patients who had cerebrovascular FMD, they all had imaging of their diaphragm to pelvis to include the renal arteries. And in this study, 48% had multi-site involvement. So they found more than 1 vascular bed or 2+ vascular beds with stenosis. And if you included the aneurysms and dissections that were found, almost 2/3 had multi-site involvement. And so this study has really prompted the recommendation that all patients with FMD at 1 arterial bed should have brain to pelvis CTA or MRA to look for FMD at other sites. How do we manage these patients? So blood pressure control is generally recommended to whatever the patient's usual target would be based on their other risk factors. If renovascular hypertension is playing a role, then blockers of the renin-angiotensin-aldosterone system may be particularly helpful. So ACE inhibitors or ARBs. And I'll note that most patients with renovascular disease can tolerate RAS blockers. It's not contraindicated even in patients with bilateral renal artery stenosis, but we would suggest monitoring serum creatinine closely for an elevated or an augmented rise in creatinine beyond what our limits would be. But most patients do not develop this and can tolerate these agents. Antiplatelet therapy, so for example, 81 milligrams of aspirin per day is recommended by some experts and is used by many. There's no randomized controlled trial to suggest that. And so it really is a balancing of potential risks and benefits. Statins are not routinely recommended for patients with FMD unless they have another indication for a statin. And of note, most of these patients are in their 50s. So in studies that have looked at this, about a half of patients do have subclinical atherosclerosis elsewhere and may benefit from a statin for other reasons. As mentioned, we screen for FMD and other vascular beds. And first-degree relatives who have any symptoms to suggest FMD, including hypertension, should be screened for FMD. And then the next question in the management is who should undergo angioplasty and when. Back to our patient, we discussed aspirin, thinking about whether she had any increased bleeding risks and really that the benefit is unknown, but she decided she did want to proceed with a low-dose aspirin. We ordered an MRA of her carotid, vertebral, and intracerebral arteries to look for FMD at those sites. And she was instructed that any symptomatic first-degree relatives should be screened for FMD. And then what about angioplasty? So I'll go through some data looking at angioplasty outcomes in FMD. We don't have any randomized controlled trial data, how we have it in atherosclerotic disease. We don't have any for FMD. And as mentioned, we really can't apply that data to these patients. So this is a meta-analysis published in 2022 looking at over 1,100 patients. The vast majority had technical success. There were some puncture site complications in 4%. About 37% had complete hypertension cure. However, of note, if you looked at studies that had more than 20 patients, it was only 18%. But the vast majority, over 80% of patients, did have hypertension improvement. And there was reporting of whether there was restenosis in only 11 studies, and the restenosis rate was 14% at 1 year. But, this meta-analysis has substantial heterogeneity and varying follow times, as well as definitions of hypertension as well, varied between the studies. Another data set to look at is a retrospective review of the Arcadia poll registry. So these are patients that were also involved in that study of systematic screening. And 203 of these patients had renal artery FMD. 61 arteries were treated with angioplasty, and 51% had restenosis after a median of 5 months. So really high rates of restenosis, with clinical restenosis in 47%. 9 patients had stents as their primary procedure with very high rates of complications. So really, stents are not recommended as the primary procedure when we are intervening with FMD, and angioplasty without stent is what's recommended. Stents are reserved for periprocedural complications of angioplasty only if needed. And in these patients, even in patients with restenosis after angioplasty, poor outcomes with stents were seen with high incidences of renal artery occlusion. And so it's possible that even patients who have restenosis should be considered for surgical management. But really, I mean, this is retrospective data. We really don't know exactly when angioplasty should be done, who's at the highest risk of restenosis. What we do know, based on the data that we have from that meta-analysis I presented, and there's other studies to support this as well, is that patients who are younger, patients with a shorter duration of hypertension, and patients with focal versus multifocal FMD generally respond better to angioplasty. So with this patient, the risks and benefits and potential benefits were discussed with this patient. Taking into account her particular priorities, she did not like being on 3 antihypertensive medications, and priority was trying to limit medications. As well, in this patient, she had a shrinking kidney, and so the potential for renal preservation with angioplasty was discussed as well. She did have a hemodynamically guided angioplasty performed, and after the procedure, her blood pressure is now very well controlled on only 1 medication. After angioplasty, practices vary with regard to antiplatelet use. Many patients do get continued on low-dose antiplatelets. Patients should have very close follow-up. When restenosis does occur, it often can occur within the first 6 months. So patients should have their blood pressure monitored both immediately after the procedure in order to ensure that blood pressure is not going too low, and then closely after the procedure to ensure that there's not evidence of clinical restenosis. They should have periodic and early monitoring with duplex ultrasound to look for restenosis. Again, based on expert recommendations, there's really not much data to support this. And we should have periodic follow-up both of kidney function and albuminuria. Seems prudent in patients with renal FMD. In patients who do or do not have angioplasty, but just in general, patients should have frequent blood pressure monitoring. Monitoring for new signs or symptoms of FMD and other vascular beds, because as discussed, we really don't know if there's a high likelihood that it could develop in another vascular bed after that initial screening is done at time of diagnosis. Patients with renal FMD should have creatinine and proteinuria monitored, and smoking cessation advice is important if patients are smoking, given the association with worsening disease. If known renal FMD, then periodic monitoring with an ultrasound plus or minus a duplex can certainly be considered. For my take-home messages, I just want to highlight that FMD is a distinct entity from atherosclerotic renal artery stenosis with different diagnostic and therapeutic implications. CTA is the best non-invasive test for renal FMD. MRA is another option and can be considered. And duplex ultrasound can be done, but keeping in mind that a normal duplex does not rule out renal FMD. In patients with FMD, it's important to screen for evidence of the disease in other vascular beds, and this is generally done at the time of diagnosis. It's unknown whether patients should be rescreened at a certain interval, and at this time, not generally done. And hemodynamically guided angioplasty may be more effective in patients who are younger, those with recent onset hypertension, and also those with focal FMD.